including India, where I am right now situated. I am Dr. Sandip Prabhakar Bhurke on the episode of World Kidney Day Kidney Health Campaigns. So today is World Kidney Day 2024 campaign, and all over the world, nephrologists, kidney doctors are telling people about the news of World Kidney Day, the disease of kidney problems, and the various treatments available and prevention techniques which are available. So we have a live chat also. You can post your questions and I can answer them for you. So first and foremost, the World Kidney Day is a uh, health day that is sponsored by the International Society of Nephrology (ISN), and it is also associated with the IFKF WKA, that is the International Federation of Kidney Foundations and World Kidney Association. So it is a copyright of those two organizations actually, and it has been going on since 2006. And every year one theme is given, and this year the theme has been the patient education basically and prevention of the various problems of kidney rather than treatment, which was the previous aspects of the themes of World Kidney Day. We had themes in which controlling diabetes, we had themes in which taking adequate water intake and other things. So right now we are having the theme where we are more into the administrative aspects of spreading the kidney care to all the population, including the disadvantaged population which is present in the world. So coming to the basics of kidney, the first basic of kidney would be the organs of kidney itself. We have two kidneys in our body, of course, and they are situated on the back side near our spine and below the ribs. And then we have the kidneys functioning basically, as everybody knows, to form urine in the body, and it basically forms the fluid balance in the body. Now, the kidney also has other functions like controlling the hemoglobin level in the blood, the bone metabolism in the blood body, and also we are having the metabolic parameters like acidosis, alkalosis, etc., which is a little higher level for the general public. And we have the kidney work functioning to remove the various poisons from the body, like creatinine, which is a well-known poison from the body, phosphorus, uric acid, potassium. All of these things help us to know about the kidney capacity to function. So first and foremost, whenever we drink any water or any fluid like tea, coffee, cold drinks, or even our food is carbohydrate. So whenever we are having carbohydrates, so in this the carbon and hydrate is there. So the body digests all the food, and the carbohydrate carbon converts into carbon dioxide and is exhaled out from the lung, while the hydrate converts into water. So even if you will ask any dialysis patient, the dialysis patients will tell you that they don't drink any much water, but still the weight gain is there. They are now having zero urine output, but still the weight gain is there, and that fluid needs to be removed by the dialysis machine. So carbohydrates are digested by the body, and finally water is formed, even if you are not having any water intake as so much. So the fluid accumulates in the body if the kidney is not working, leading to swelling of the feet and water going up into the lungs and causing breathlessness and like breathing difficulties, as you will say it. The kidneys are the main organs, the only organs which produce erythropoietin hormone in the body, and this is a signal to the bone marrow. The bone marrow is the factory which is producing the red blood cells, the hemoglobin, while the signal whether to work or to stop work, that is the erythropoietin from the kidney. So whenever the erythropoietin is formed by the kidney, the hemoglobin is formed. And if the kidney is non-functional, then the hemoglobin does not form. Even if all the apparatus is available, they do not function. So that is why kidney patients who are having failure of the kidney, completely weak kidneys, who are on dialysis, they will require erythropoietin injection to be taken maybe once a week or once in a month to see to it that their hemoglobin is at a proper level. Many people ask me what is the normal level of hemoglobin required for a kidney patient. So the hemoglobin level required for a kidney patient is usually around 10, but for a normal person who is healthy, it is usually around 12 to 13. So the erythropoietin is not required if you are near 10, 9.5, 9.7, slightly below the level of 10 which is required. Then you will not require the erythropoietin injection to be given. Another aspect of the hemoglobin production is that if you are planning to require to give hemoglobin to the patient, hemoglobin increasing injections to the patient of erythropoietin, you will first have to check whether there is a iron stores in the body. So for the first time, whenever you see a patient and the hemoglobin is less than 9 or so, then you will give first a blood test report of iron studies in which transferrin saturation is checked, and that should be around 35% or so. If it is on the lower side, first and foremost you will have to replenish the iron, and then you can start the patient on erythropoietin. In such cases, you should also check for stool routine microscopy occult blood daily for 3 days, not only a single report, but daily for 3 days. And in that, you will see whether there is any occult bleeding in the stools, which is causing the hemoglobin to fall. That may also be present in patients who are sick. Now, whenever you are having a stool occult blood report which is positive, you should always do the stool routine microscopy occult blood, because there may be worms in the stools, there may be cysts and ova in the stool. So these all things lead us to finding out the cause of the anemia, the fall in hemoglobin, the loss of blood in the stools, and that appropriate measures can be taken. I think audience has asked what are the major factors for kidney disease. I'll be coming to that in just some time. So coming to the functioning of kidney, in that we have the bone metabolism, which is also a good functioning part of the kidney metabolism. In that, calcium, phosphorus, uric acid, parathyroid hormone, these are intricately connected, and the bone is maintained by the kidneys finally. So whenever the kidneys are not functioning, the calcium falls, the parathyroid hormone increases, the phosphorus increases, uric acid increases. So all this leads to a bone metabolic disease in the body, and that can be corrected by supportive medications and of course by cleaning up the poisons by dialysis. Sorry. What I'm telling, the word poison is not really the big poison which you know about. I am talking about the routine metabolites which are not required by the body. So they are not really poisonous, but in a higher level they will cause problems to the body. In such cases, the creatinine, uric acid, potassium, phosphorus, these are the ones which are present in you and me as a healthy person also, but at a routine level of maybe 1 milligram percent of creatinine or 0.7 milligram percent of creatinine, 88 millimoles per liter of creatinine, and the SI standards. But in a kidney weakness patient, kidney failure patient, they can go up to 10 times higher, 15 times higher, and we will then require the cleaning of the blood by dialysis. Previously, we used to think that dialysis is an end stage renal disease, end stage kidney disease, and the patient is going to die. But that is not the case currently. The machines have improved, the medicines have improved, diagnosis is faster. So nowadays it is almost impossible for a person to die because of kidney. But the routine problems which cause the kidney failure, like diabetes or hypertension or kidney stone or painkiller abuse, that will also affect other parts of the body. The heart would be weaker, there will be atherosclerotic plaques in the coronaries, arteries of the heart, and that can lead to heart attacks. So usually a dialysis patient will not die because the dialysis machine itself is an artificial kidney, and that is removing all the poisons like creatinine, potassium, phosphorus. But later on, because of old age or because of weak cardiac heart factors, the patient death may occur. But still, nowadays, compared to the previous 40 years back, if you will see, dialysis patients can survive up to 20 years, 25 years on dialysis also, and that also a good life. It is not that they are bedridden and they are unable to manage themselves. Many dialysis patients who are on the younger side, they can go to work also, and they can drive cars, they can go on vacations, they can have their family work also, and they take care of their children and everything. Like they can also fight with their spouses, wife or husband, whatever it may be. Coming to the next part of dialysis would be of course kidney transplantation, and it is done in person who is below 60 years of age usually. In that, Usually in India we have the Human Organ Transplant Act (HOTA), and in according to that, a living related donor is the usual transplantation which a nephrologist does in India. In America, USA, rarely, many times actually, we may be having things like what you can say, a goodness transplant. Somebody unknown thinks that they will help somebody out of the blue, and they go to a hospital and say, I want to donate my kidneys to anybody who needs it, and they give it. But in India, such things usually don't happen without a transaction of money. So the government interview is taken of such patients, and only if the government is having proof that this is not a transaction for money, then only these transplants are agreed, which is very rare in India. So in India, the nephrologists do get phone calls maybe once a week, once a month, that my mother is ill, I have financial problems, I want to sell my kidneys, how many crores will I get? So we politely tell these people that this is not possible, first and foremost, and it is illegal, second. So don't try to go on doing this, because you may fall into a legal problem later on, you may get arrested. So a few times the people persist, and then I really have to block their phone calls, because I have told them one or two times I cannot keep on taking phone calls of such people, because it is actually illegal. So coming to the question which was asked, what are the major factors for kidney disease? So I would say the number one factor for kidney problems is, of course, diabetes. And if you enter a dialysis unit, then around maybe 50 to 60% of patients on dialysis will be the ones who are having the kidney failure because of problem, because of diabetes mellitus itself, sugar problem. A few of them will be because of blood pressure, hypertension, and the remaining ones, few of them will be stone related disease, and very few of them will be painkiller abuse, NSAID abuse patients. And also 10% of the patients in such every dialysis unit, of course, will be unknown cause. If you see, there will be a 17-year-old girl or a 15-year-old boy, you have some small minor things and they are checked up, and suddenly the creatinine comes as 17, 18, 19, and the kidneys are shrunken and small, and whatever tests you do, blood tests, urine tests, you possibly, sorry, but you don't come to know the cause. Medical science is not that advanced that you will come to a cause for every single thing which you know. For example, if I myself have a cough and I take some antibiotic, my cough goes away, and then the next person asks me, Dr. Burke, what was the bacteria or virus in your lung? I have no answer. So medicine does not have all the answers, but majority of the answers we do have. Coming to the problems of diabetes and kidney, whenever a diabetic patient is having uncontrolled diabetes, that is an HbA1c more than 6.5, then of course after few years, actually not within few months, there will be proteinuria in the urine, and the proteinuria will be on the rising trend, and later on the creatinine starts to rise. And a creatinine of 2 usually means that the kidney function has fallen by half. So the GFR from maybe 90, 100 has come down to 50, 45, like that. And the creatinine, when it doubles again to 4, then your kidney is usually working around 20%, 25%. And the creatinine reaches around 6 or 7, then usually your GFR is only 10. So your kidneys on both sides are working only 10%, which is usually not enough as a life-saving thing for the body. And then we usually tell the kidney patient to construct an AV fistula on the left hand. So that may not mature in few patients, unfortunately, and in majority of the patients it will usually take around 1 to 2 months to mature fully. So when you are foreseeing that someday the patient is going to require dialysis for lifelong, you will require the patient to construct the AV fistula. You will request the relatives and patient to do the AV fistula on the hand beforehand, rather than waiting for something to happen and on an emergency basis you require dialysis. It sometimes does happen that the patient refuses, or they don't know anything, they don't go to a nephrologist, not properly investigated possibly, and then they come in a breathless condition or severe vomiting or in an unconscious state because of very high creatinine. In such patients, you will do a dialysis through the dialysis catheter in the neck. and emergency dialysis would be started. After that, the sonography Doppler of the hand will be done for the arteries and veins. And finally, you will go on to possibly a need for a perma catheter, which comes out of the chest rather than the neck, if the veins of the hand are very poor in a diabetic or in a lupus erythematosus, SLE patient. Coming to kidney transplantation, live related kidney transplant is done between the father, mother, brother, sister, or spouse, that is husband and wife. And rarely it is the children giving to the parents. Usually they are married and having children. The donor is settled in life and financially, and they do help their parents sometimes. That's a rarer thing. Beyond that, if you will ask me, the other persons like uncles, aunties, mother-in-law, father-in-law, they are also accepted after a proper government interview, whether there is no financial transaction which is there. Some people do ask me that why not the government allows what you can say selling of the kidneys legally. Well, it has been seen that then it becomes a market for the organs, not only kidney, other things also. And then the bad elements come into the market for black marketing, which happens. And it may not really help the person who has donated the organs. Now, suppose somebody, just a logic, not a true story. Suppose somebody who is really very poor and he is requiring organ, kidney for transplantation. So he is searching around for an organ, and a poor person who is needy for the money, he says, yes, I will want to donate my organs. And that person is poor because they are at that moment in a little lesser educational qualification. They are not financially that literate that suppose I get some money today, then I will invest it in a property or in a bank. Like that may not click to them. And suppose then the donation is done and the poor person gets a lot of money, a million of rupees, 10 lakh rupees, 1 crore rupees, 10 million rupees of India, of course. Then that poor person will first and foremost go and enjoy life because he has never gone into a expensive place. He may not do the proper investment things which are required. And it has been found that somebody who is not rich becomes actually more poorer because they go into gambling and giving money away for other people like relatives and friends. And finally you will find that they are poorer than what they started with, because they are now debt ridden. They will enjoy their life and go into more depth, and they will not you will say finally have a good life later on. So there is something called as the disease donor. Previously it was called cadaveric donation. In this we see that the cadaveric donation, whenever there is a accident or a brain IC bleed, intracranial bleed at home also in old age persons, then if the brain death has happened, brainstem death has happened, and it is certified by a group of doctors who are government certified that of course the brain is dead but the organs are alive, with the heart is still beating, which is still a form, not a form of that actual death itself. The brain is dead, there is no soul in the body. Then in such cases the government approved transplant is done, and the organs with like heart, lung, liver, intestine, bone marrow, kidneys, almost everything can be donated with the permission of the relatives, and they are distributed only as per the government list. The hospital has no say in who is going to get the transplant, the kidneys or liver for transplant. You may have seen a WhatsApp message which is or a Facebook message which is going on that 4 kidneys are available, you can come and take it. There is a couple who is brain dead, but that can never happen because you cannot just go and take kidneys like you go to a market and take something. The kidneys and organs will be distributed only as per the government guidelines and as per the government already existing list which is there. Every person has to register first, and usual waiting time in India is around 3 to 5 years to get a kidney on the waiting list as per their blood group. Then we will come to the organ donation which can happen at home. At home, the organ donation can be only the cornea, eyes, and the skin, which is taken from the thighs or from the back. And in that cases, whenever a death happens at home of an old age person, of course, then we will request the relatives to put wet handkerchief on the eyes so that the eyes don't dry. Switch off the fans in the room so that the eyes don't dry. You can put on the air conditioner, no problem. And then you immediately call the local eye bank. Lions and Rotary Trusts are having also helplines. Government of India is also having a helpline. These all will help the person to doctor to come to your home, check the death certificate that there was no infection, septicemia, etc. And they'll take a small blood sample from the dead person for checking for the other infections like HIV, etc., which is mandatory. And they will then take the cornea or the skin in a separate room and hand over the body back to the relatives. And it is not disfigured. Don't worry that it will not look very bad or something. Even when you are doing the disease donor donation, the operation for removal, that is retrieval of the organs, is done from the neck below. The upper part of the body, which is usually open of a dead body, is not disfigured at all. And even when the organs are removed, it is by a different surgical method, correct surgical method only. And it is closed also by a surgical method. There is no tearing up of the body, etc. That is not done. We have a question: is there any unique symptom for kidney disease? Like, when should you consider a checkup? Yes, there are things like asymptomatic kidney disease. Few of the times, as I told you, you just go for an insurance checkup or a job checkup, and you find that you are having protein in the urine, or unfortunately, your creatinine is already high. Then, of course, there will be urine tests, there will be blood tests, there will be sonography, there will be special tests, including eye fundus, the backside of the eye, for hypertensive or diabetic retinopathy, autoimmune workup, ANA, dsDNA, etc., anti-nuclear antibody for lupus nephritis, collagen vascular disease, etc. There's a long thing of list to be done. But sometimes there may be no symptoms at all. The person just out of the blue comes to know that there is an ongoing kidney disease, which may be mild or it may be advanced also. While majority of the kidney disease patients will have swelling of the feet, the swelling of the feet will be the first symptom which the patient has, and they will go to a general doctor who will then check the urine routine and the creatinine in the blood, and then refer to a nephrologist for further care. So whenever the young person who is not a diabetic is having proteinuria or high creatinine, usually it is required to do a kidney biopsy, except below the year of 12 years of age. In children and babies, usually kidney biopsy is not required. The pediatrician usually treat the patients with steroids, which is on a higher level, which is safe for the kidney. It is actually helping the kidney. And later on, the baby becomes all right, and maybe by 12 years of age, majority of the times the disease goes away and does not come back. There are remissions and relapses, that the disease sleeps and relapse, that it comes back again. That may happen in young children. And also, one very important thing which the nephrologist doctor has to inform the family is that steroids are a very good help to the kidney, but do have side effects which are to be accepted. You're not going to cancel treatment because you're afraid of side effects, which are minor things finally. But one side effect is the steroid face. There will be an increase in the size of the cheeks, and it is very obvious to other people, and that is why you will feel that what is going on with my patient, what did a doctor do to my patient. So that thing has to be told beforehand, before you start steroids for a patient, especially in children also. And vaccination for influenza, pneumococcal, hepatitis B, these are the routine things which are done for almost any kidney patient having a need for immunosuppression later on. Whenever an adult has proteinuria or a rise in creatinine who is not having diabetes, then usually it is a kidney biopsy, needle test of the kidney, which is required. It is not an operation, and it is not cutting of the kidney with a knife or anything. It is just like a blood sample. With a needle, we take a sample of the kidney tissue, and that is sent for electron microscopy and light microscopy and immunofluorescence. Whenever we are having the disease which is possibly recoverable, again in adult, steroids may be given or higher levels like tacrolimus, mycophenolate, rituximab, cyclophosphamide. These all are steps. Whenever you don't improve with one stage, you go to the next stage, you go to the next stage. So unfortunately, there are few patients who do not respond to treatment, and they may finally go on to dialysis and transplantation even after treatment by a qualified nephrologist. So it does not mean that you go to a nephrologist and the nephrologist will 111% cure your disease. Kidney disease management has not gone to that much of a level that once you go, you will completely be cured. Just like tuberculosis you will usually be completely be cured, but in kidney disease you may not be completely be cured. It is the trials of the nephrologist doctor to try and fight with the disease which is present in the body. Rarely the kidney biopsy, which is a test, it is not a needle giving an injection of medicine inside the kidney. Then in that case you may get a report that the kidney is not recoverable at all. Means there is something in the kidney which is end stage already. So in such cases, we will see that the patient is then just given supportive treatment, whatever may be the proteinuria or creatinine, and we do not usually give immunosuppression to this patient. And a slow rise in the creatinine is going to happen even if you do maximum possible for the patient. Finally, we will see that the patient goes on to dialysis and kidney transplantation, but these are the rarer things of such patients. If a diabetic patient is present and the diabetic patient is having a proteinuria and he is having a slow rise in the creatinine, usually the nephrologist will investigate by history taking, and we will see that the patient is having uh, diabetic retinopathy, other end organ, target organ problems like LVH in the heart, or diabetic foot previously, or paralysis, CVA previously. So the diabetic patient is having different problems. So in that we come to a conclusion that the kidney disease is also a diabetic disease, and usually the kidney biopsy is not required except if there is a hematuria, blood in the urine, or a very rapidly rising creatinine, which is not expected in such patients. So a diabetic patient is going to have a slow rise in the creatinine. We give supportive medicines like antioxidants, N-acetylcysteine, taurine tablets. We give keto analogs which reduce the nitrogen load in the body. So all this will reduce the load on the kidney. They may not correct the kidney problem. You may not have a reversal of the kidney problem. You may not have the kidney level remaining static at whatever 2.2 creatinine for lifelong. That is all falsehoods which some patients think it should be told by the doctors to them. You are having a kidney disease, and usually the kidney disease is going to rise. In a diabetic patient, there is one disease called as emphysematous pyelonephritis. Whatever we have the diabetic foot, that there is a gangrene of the fingers of toes of the feet. The same bacteria infection in an uncontrolled diabetic patient will be there in the kidneys. So there will be gas gangrene of the kidney, and there will be air bubbles on the CT scan of the kidney. And this is a very, very life-threatening thing and requires urgent ICU admission. We need to keep these patients under observation with very high levels of antibiotics, supportive care, maybe need of dialysis. And the urologist doctor, the surgery doctor may require a DJ stenting, PCNL, or very rarely even removal of the entire kidney to save the life of the patient, because usually these patients are in septic shock. So, ICU patient themselves due to other causes like malaria, dengue, bleeding in the intestine, or post delivery in a pregnant patient, there may be issues with the kidney, and such patients usually have the cause known. So, we will try and correct the cause if it is possible, and give supportive management like IV fluids, inotropes, blood pressure increasing injections, etc. to the patients, and try and save the life and the kidney of the patient. Many patients will ask us what is the future of kidney dialysis? Do we have portable dialysis? Portable dialysis at this moment is only the dialysis machine itself, which is usually the size of a fridge, brought to the home, and the dialysis is done at home. That is one hemodialysis aspect. The second is the peritoneal dialysis, in which the medicated water is put into the stomach, the abdomen actually, and then it is emptied out. So dialysis happens without blood dialysis. That is just a medicated water dialysis. But portable dialysis, where you can walk around with dialysis happening on your stomach or on your hand, that has still not come, and it is going on rats, and it coming into the market will take a lot of years. I'm not expecting it to come in the next few years also. Many patients do ask what about the medicines? What if I don't take the medicines? Usually, the kidney patients are given supportive medicine, except for the collagen vascular disease, where steroids or curative medicines, which are higher level, are given. Rest of the drugs are like calcium, uric acid lowering medicines, vitamin D. All these are supportive medicines, but they do help the kidney to recover partially and the slow down the increase in the creatinine. It may not reverse, it may not stop at one level. So in such cases, we will think that it is very necessary to continue the medications and try, and if there is a swelling of the feet, try and reduce the fluid intake so that the fluid does not go up into the lungs and cause breathlessness. So coming to the next aspect of kidney would be the uh, biopsy things. Biopsy is a indoor procedure. It is not a OPD procedure. Usually we admit for 1 to 1.5 days. It is done under sonography guidance, very rarely under CT scan guidance, and the samples are sent to a specialized laboratory. Usually the hospitals, even if they are big hospitals, do not have in-house processing for kidney biopsy. Even in Indian cities, we require to send them to a specialized lab, which is maybe one or two in the city of Bombay, not everywhere, not in every hospital. And the cost of the biopsy is something which is on the higher side compared to routine blood test, but it is required, then it should be done. So I will request any more questions from your side. Just 2 3 fans of mine saying hello to me in the live chat. You can ask more questions on the live chat if you require to. So one aspect of kidney problems is the painkillers. The painkillers like diclofenac, etc. They are harmful to the kidneys. We have taken for a very long time. Previously, they used to be over the counter, and anybody would just buy and continue taking it for years together for knee pain or backache. But nowadays, with the government regulations, pain and the awareness of the general public that painkillers are not good for the kidney, it has stopped usually. And majority of the patients nowadays do not come with kidney failure because of painkiller abuse for a long time. Ayurvedic medicine, which is the indigenous Indian medicine from thousands of years, actually 5,000 years, 10,000 years, the Ayurveda is there, the Vedas of the Hindus. In that, it is said that most of them are plant based and safe for the kidney. But in the nephrology field, we say that the bhasmas, that is the heavy metal used in the Ayurvedic medications, can cause damage to the kidneys. So if you are taking indigenous medicines of India called as Ayurveda, then we usually request the patient who is already a kidney patient, when they come to a nephrologist, to try and stop the bhasmas at least, and to monitor their blood test, etc. Monitoring of blood tests is a, I would say, monthly affair for kidney patients. Usually, we will do the simple tests of creatinine, electrolytes, urine routine in a diabetic once a month, because there are fluctuations in this. And once in 3 months, we will do the rest of the tests like CBC, creatinine, electrolyte, calcium, phosphorus, uric acid, and iron studies, T3, T4, TSH, HbA1c, fasting glucose, and post lunch glucose if required. Once in a while, we will do HIV, HBCG, anti-HCV for the vaccination purpose, and the parathyroid hormone is checked once a year. The fundus of the eye is checked once a year. 2D echo of the heart is checked once a year. So, a kidney testing involves testing of the other organs of the body also. A nephrologist does interact with other doctors also. There will be the general doctor, the MD physician doctor, the diabetologist, physiotherapist, and podiatrist who take foot care of the diabetic persons because they have less sensation on the foot and they get wounds on the foot, which are non-healing sometimes. Then hyperbaric oxygen therapy providers. So there is a lot of people who are involved in the care of a single person also. Of course, not forgetting the dietitian. The dietitian would modify the various aspects of kidney diet, and it is said that many people ask me whether to stop non-veg completely, whether to stop proteinaceous vegetarian foods like dals and pulses completely. That is not required. Usually, if you eat food, kidney is not going to get damaged. If you starve, kidney is not going to become all right. There is moderation which is advised, and but not stopping any food. So if you are a non-vegetarian person, whether you are Christian, Muslim, or Hindu, you are allowed to eat in a smaller quantity. And if you are vegetarian, then paneer, soybean, mushroom, and such good quality proteins, class 1 proteins, are the ones which are continued. Coming to the vaccinations for influenza and pneumococcal are very important for all patients. Hepatitis B vaccination is also given, and this is as per the CDC guidelines of USA. And whenever a patient comes to a nephrologist, usual time required for examining the first time patient is usually around 20 minutes or so, taking a detailed history. Examination is not that much, but explaining to the patient requires around 5 to 10 minutes to make them understand that possibly the kidney is not recoverable. If, as a nephrologist, we find that a person is CKD, that is, we are not finding an AKI, acute kidney injury, then it is very important for the doctor to be very clear to the patient that your creatinine is going to rise slowly. That is very important to clear out any misunderstandings in the patient, that because he has come to a doctor, his creatinine is going to go down. That may not happen in CKD patients, especially who are diabetics or who have shrunken kidneys on sonography. So it is very clear to explain to the patient completely that this is uh, non-recoverable and slowly progressive disease. We have a question: what is bone TB? Well, bone TB is a completely separate topic compared to kidney, but I will tell about the kidney TB. Tuberculosis is fine, usually associated with lung and cough in the throat, but tuberculosis can also happen in the kidneys, and that can lead to blood in the urine, abscesses, tuberculosis abscesses in the kidney, and that can lead to structural damage to the flow of the urine and causing choke up of the urinary tract. And that is usually then investigated by urinary AFB test or by needle testing biopsies of the kidney or of the pus collection, pigtailing, and then later on we treat them with tuberculosis drugs for around 6 months to 2 years. Sometimes they may be MDR TB, multi-drug resistance TB, and they may require higher level of medications for a longer time. So I will now end my live chat, and if there is any more questions, you can post your comments, and I'll be glad to get back to you. Thank you.